We will be recording this session now. Cool. Lovely. Alrighty, before we get started though, we would like to acknowledge the traditional owners of the lands that we're meeting on today. So today we're calling in from Borlu, also the traditional lands of the Whadjuk people of the Noongar Nation. So we're based here in West Perth, and we pay our respects to the elders past and present of the lands that we're meeting on today, and also extend that respect to the elders past and present of the lands that you're all calling in from today. I know we have people calling in from different areas across the state, so we would like to extend that respect to the lands that we all do our work and live our lives on, and acknowledge that what always was and always will be Aboriginal land. Awesome. So a little bit of housekeeping before we get into the session today. So the data that we're going to present, we will go through a little bit of epidemiology at the beginning of the session today. So all the data is from the Department of Health, from their they have the surveillance, or not the surveillance of the notifiable disease dashboard. It's current as of the creation of this presentation. So I went, actually skip that, whoops, went and updated the information yesterday. So that's current as of yesterday, and I have got that as a date on there too. So we send out the slides after this session today, just be aware that that is current as of today. Sometimes the information on that dashboard can change, and obviously does update as information becomes more available. So just being aware of that, a full disclaimer. If you do have any pressing questions, you can pop that in the chat. We will be trying to get through the content today as much as possible in one kind of lump, and we can answer questions at the end. So we obviously don't want you forgetting any of your questions, so you're welcome to pop them in the chat. We just may not be able to come to them right away. Please keep your microphones off as well. Once we get to the end there, you're welcome to pop your microphone on to ask any questions or pop them in the chat, but we just ask so that the session can run smoothly today, that we all keep our microphones off. If you have any questions, again, no such thing as a silly question. If you're wondering it, guaranteed other people are also thinking it as well. We're all coming here to learn. We may all have different understandings and different backgrounds in terms of our professional kind of work. So everyone's here to learn, and we may be coming from different levels of understanding around the topics we're talking about too. So just respecting any kind of questions that are asked today, and yeah, we'll hope to answer any questions that people do have. And lucky last as well, we'll send out, and at the end there'll be a slide with a QR code with a little brief evaluation. We would really appreciate if you were able to complete, just so that we can monitor the, I guess, effectiveness and also how the sessions run today, and can inform our future sessions too. We'll also send that out in a link in the email following up from today's session. Lastly, just want to give a bit of a content warning. So we will be going through some clinical presentations, and that will include images as well of potential clinical presentations with syphilis symptoms. So some people may find this quite confronting, maybe not always something that they want to watch or look at while they're eating their lunch. So just be aware that that will be coming up in the first kind of half of the session today. So when we start looking at clinical presentations, just be aware that the next couple of slides will be of images of some chancres and rashes. So yeah, just be aware of that. And also aware of other people around you who may walk past your computer and spot that without any context. Very quickly, so we're going to go through some epidemiology, look at clinical presentations. We'll then look at the testing involved for syphilis, briefly look at congenital syphilis, and then we'll look at interpreting results. We're going to do this through some case studies. Following up by looking at the different treatment options, then we'll go through kind of following up after the test and after a positive result with contact tracing, and then look at some kind of tangible, kind of practical tips for normalising conversation as well with our patients, clients, or community members, whoever we kind of work within our scope of our roles. So without further ado, we'll get into a little bit of epidemiology. I mean, I personally could talk about this all day, but we're definitely only going to spend a little bit of time on this today. So as most of you would be aware, the last few years we have been in a syphilis outbreak within WA. So we've got here the notifications within WA between 2020 and 2024. It's promising there has been a bit of a decrease in the recent years, or the last 2 years, in terms of syphilis notifications. As of yesterday, we'd had 87 cases notified or available on the database in WA for 2025. Unfortunately, usually they'll have a kind of a 5-year average comparison point for this point of the year, but I believe that isn't actually working at the moment. So it's actually just giving me the whole year kind of average. And I was thinking, wow, 605, but turns out that's just for an entire year. So yeah, about 87 cases at the moment. So we are kind of tracking down, and that speaking to Department of Health, they had said at the last quarterly forum that they're believing this kind of trend hopefully is in relation to the increase in testing, and that huge increase in testing we've seen particularly in regional areas and metro areas as well. But still a long way to go to kind of get it down to pre-outbreak kind of levels. In terms of congenital syphilis, so really big positive last year. There was no recorded cases of congenital syphilis for 2024. So the previous few years we had seen roughly around 4 syphilis or congenital syphilis notifications between 2022 up to 2023 for each year. And so far this year as well, for 2025, we haven't had any notifications of congenital syphilis, which is awesome. Just comparing here, just briefly looking at within the different regional areas of WA. So we have been seeing decreases in, particularly in areas that were quite endemic areas for syphilis. We're particularly looking at like the Kimberley and the Pilbara. We have been seeing there has been notable decreases in syphilis notifications, which is really, really awesome. And also some decreases in other areas as well. So it's really important that we're continuing the testing and our I guess communication with community about the importance of testing and being aware of syphilis, but showing that hopefully this means that efforts are being really effective, and this is quite positive to kind of keep us going in this outbreak to continue bringing the cases down. Lastly, just wanted to touch on looking at the kind of age distribution last year. So I'd like to kind of bring this up when we do talk about any kind of STI and looking at it within syphilis as well, because often when we talk about STIs, we do talk about them within the kind of context of that kind of 15 to 35-year-old kind of age bracket. But as you can see here, whilst there is a high number of cases within this age kind of demographic, there are still cases either side, but predominantly looking at kind of the over 35 as well, that there are still cases being detected, whether they are new cases or kind of later stage with syphilis as well. So just being aware that it isn't just, when we're talking about STIs, that we're not just kind of talking about that 15 to 35-year-old age bracket. People of different ages have sex or have had sex at some point in their life. So really making sure that we're not kind of ignoring or kind of becoming a bit more, not kind of focusing on kind of older age demographics or above age of 35, which is not older. That's but also interesting as well, just breaking it down as well by the ratio of male to female notifications. So there's about a 2-to-1 ratio. So every 2 notifications in males, there's 1 notification in females. There could be many reasons for this, but there has the Metropolitan Syphilis Response Outbreak Team, or MSORT, had identified the gay, bisexual, men who have sex with men population as a priority population within the syphilis outbreak. So it's important to kind of really continue health promotion efforts to ensure that the population remains aware of syphilis, but also are getting tested as well, because there's higher rates being seen in this population too. I think you wanted to add on there with the Eddie?
No, I think that's good. Thank you.
Perfect. Alrighty. So over to Gary for the clinical presentations.
Okay. So syphilis is one of my favourite STIs. It's always fascinating, and there's always something new to learn. So I think one of the main things to remember is that syphilis is often asymptomatic. So I don't know if you've ever had people come to you say, I'm sure I've got nothing, I've got no symptoms, and then the bottom line, no symptoms basically means nothing. So when talking about syphilis specifically, if you do have someone present with some specific, what I would call classic symptoms, you're really, really lucky. But as we go along a bit, it can present in all sorts of ways that you're not expecting. So from my point of view, if someone's coming for an STI check, I suspect every STI on the planet. So anything that does look a little bit suspicious, I just say test, test and test. So, so with primary syphilis, if we're really lucky, we've got some lovely pictures coming up. The people can present with often a painless ulcer, which is usually quite indurated or quite indented. It could look very red and sore. Often it's not painful, and that can be oral, could be on the tongue, could be on the lip, genitals, scrotum, penis, perianal, on the labia. So from the time of infection to the time when you're going to see a particular lesion, average is about 3 weeks. So within about 6 weeks, these ulcers will heal. And the problem is if it's painless and it's somewhere where the person can't see it, so if it's in the rectum or if it's in the mouth, it's not painful, they ignore it, then it's going to heal, but it's still, the syphilis is still around. You do develop antibodies, but they're non-neutralizing antibodies. So the syphilis will be there forever until treated. So with secondary syphilis, this can be a few weeks to a few months, where some people will present with, can be a scattered, can be a relatively localised rash to quite widespread. And often with that, but not always, as I said, don't trust them, they can have quite marked fatigue, muscle aches and pains, joint pain. Some people will actually potentially present with neurological symptoms, such as vision or hearing disturbances, balance. So if you're thinking somebody might have secondary syphilis, and even with early syphilis, it's always good to check all those general symptoms. And I'm thinking actually I've got a really good sort of checklist that you can use, which we can send out. Just so that you can go, right, check that, check that, check that, check that. And if they say yes to this or no to that, then it helps to guide onward referral. If there's any risk of neurological symptoms, such as vision disturbances or hearing disturbances, that needs a proper specialist examination and perhaps even a lumbar puncture. That's getting a little bit serious. So, though that rash is usually not itchy and it will generally resolve over time. Again, people are still highly infectious, and it's often missed even by dermatologists who think that it's dermatitis. If it's non-itchy, and I'll give you an example coming up. If it looks a bit like that, always from a sexual health point of view, suspect syphilis. So now we get, this used to confuse the hell out of me, early latent versus a late latent syphilis. So where somebody has had a negative syphilis serology within the previous 2 years and they've had no symptoms or none that they can remember, then we would assume, so what we would call it is an early latent. So within the previous 2 years, they've got a negative serology, then we will say, okay, you've got no symptoms. So basically we call it latent. It's sitting there, but it's not causing symptoms. A late latent syphilis would be one which is assessed to be of more than 2 years duration. Again, where they've not reported any particular symptoms that are specific to syphilis. Over 2 years, people are assumed to be non-infectious. You know, I don't know, just at 2 years where it suddenly stops, but that's the general thinking. However, you do have risk to a fetus if somebody's pregnant. So again, and just down the bottom there, people can remain infectious up to 2 years. It is more likely in the earlier stages, but yeah, so this is something to tell people. So with syphilis, it's never been treated. So several years to often up to decades, people can develop tertiary syphilis, which is basically life-threatening, and the bacteria gets into pretty much every organ of the body, can cause end arteritis, so inflammation of the inside of the arteries. It can cause quite significant hemorrhages, can cause syphilitic dementia, heart failure. So that is extensive treatment, and as I said, can be life-threatening. So the earlier we pick it up, obviously, the better. So we'll just move on to my little slides. Now, the one on the left, this is actually one of my previous clients. Came in for a routine check, and I know it actually looks quite faint, but that's how it presented. And it's this widespread sort of macular-papular rash, which is very medical, but it's sort of raised flat, raised flat, raised flat. Can be quite a salmon-y looking colour to a reddish colour, quite diffuse. And just happened to be that he was wearing a singlet. And I said, how long have you had that rash? He said, oh, a few weeks, but it's not itchy, it's not bothering me. So just because I've seen a lot of these sorts of rashes, I thought, I think it's probably syphilis. So we tested and I treated him on the spot. Turned out to be secondary syphilis. So, but he had no other symptoms, and because it was not itchy, it wasn't bothering him, he didn't feel unwell, he was going to ignore it. On the right-hand side, I've only seen a couple people like this where they've had, they say, classic rash on hands and feet. However, I haven't seen too many, to be honest. But if you see it, you go, "Ooh, hang on a minute, maybe syphilis." I just think everything might be syphilis. Okay, so we'll move on to a couple of other more explicit photos. So the penile ulcer you see there, everybody gets really excited when you see an ulcer like this because you can pretty much bet your bottom dollar that it's going to be syphilis. So it's indurated or indented in the middle. It's got a rubbery edge on it and can often look quite painful. Often, but not always, it will be painless when you swab it. However, if it's also got a superficial bacterial infection, then it could be painful. So now the reason for the one that you swab, you do a dry swab, always test for syphilis plus add herpes. Sometimes they like to go together. Now the PCR, the dry swab that you would do for that, will come up positive often before the serology. So that's why you want to swab anything that looks suspicious, because the blood test may actually come back negative. It can take up to 6 weeks for serology to actually show positive. On the right-hand side, I saw somebody like this several years ago, and I thought, oh, it's got to be herpes. It wasn't terribly painful, but I thought, oh, look, I better test for both anyway. And bugger me, it was actually syphilis. So I wasn't expecting it. That's why I test for this, test for that. And also recently I had somebody said they had an ulcer on their tongue. When they showed me, I had a look and I went, I can't see anything. So he said, no, it's been there. So I swabbed it, syphilis. So even if somebody's pointing to something, you can't really see it. And if you've got somebody in the so-called high-risk cohort, such as the people we see, gay, bisexual men tend to be very sociable. If they're saying they can see something, swab it anyway, just to be on the safe side. Okay.
I just had a comment here. It was pretty good to add in here. So this is from Sunny, who works at Aqua. So Sunny said, when I've seen secondary syphilis rash, Aboriginal people's hands, feet and trunk, it's darker in colour than their own skin pigmentation instead of that pink colour. So with different kind of skin pigmentation, that it may not appear that pink in colour.
Okay, well that's good to know, because yeah, most of our cohort are non-Aboriginal or non-dark skinned. We have seen a few, but yeah, this is really good to know. So thank you for that.
Thanks, Sunny.
Yeah, that's absolutely brilliant. So for basically syphilis, anyone who's tested, anyone who said I want an STI check, and this should be the same. If anyone's presenting for an STI check, really HIV should always be done unless they specifically say they don't want it, always add syphilis. So HIV and syphilis, you've got about a 6-week window period from exposure to positive serology. So if you're doing an HIV window period, always do a syphilis. That's going to be much more likely. So it's probably completely obvious, people who are pregnant or childbearing age, men who have sex with men, yes, I mean, that's our main cohort. Aboriginal Torres Strait Islander people, people that have been on overseas holidays. We have a lot of people that say, oh, I've just come back from Europe, hence I'm testing. So you can put 2 and 2 together and get 4. So now we're not specifically pointing fingers at people who use drugs, but it's probably obvious that people's their inhibitions can go out the window, tend to be maybe taking more risks or more partners than they normally. So I'll put here ulcer-like lesion. But as you've seen there, you might get a little bit of a rash. You think, oh, don't know, just test for it anyway. Also, if somebody has said that they're a contact of syphilis, especially if there's somebody with infectious syphilis naturally, we're going to test them. And if it's a very good history of contact with somebody that had an ulcer or a rash or had other symptoms, we will often treat them on the spot. And anyone presenting for an HIV test. So, but I like the little comment that Amy's put down the bottom. Test anyone, test everyone.
Can never be too sure. So don't make assumptions either.
No, never assume. I've tested men and other people into their 70s, 80s, and it's like, oh, oops, guess what? You've got syphilis. So assume nothing.
Even if you've been seeing them for many years, speaking to clinicians, have said, oh, I've seen somebody for years and years and years, I know their medical history, but unless you have tested for syphilis, how do you know? Sure, I guess in that sense. I guess if it's something that the person is happy to do, and if it's something that's possible to, I guess there's probably no harm there in testing. I think it'd be better off to know.
Well, one of the doctors that our medical director, there's an assumption because you've been seeing somebody for many years who's been married. There's an automatic assumption that it's monogamous. Could be, may not be. But the other thing is that if we're looking at people that might be into their 60s, 70s, been married for 30 or 40 years, they may well have had sex before they got married. And I had a situation like that with a chap who'd been married for 40 years and got tested, discovered that he'd had syphilis. Turned out that we worked out it was a latent, long-standing infection. So you just can't assume. And one of the things that this doctor suggested is that a routine test, even with somebody that's older, to say, we often do a routine syphilis check. You may have had it for a long time. We just want to check. So it's something worth considering. Okay, so syphilis serology can be tricky. It took me quite a while to really get my head around it. So, and if anyone did have any particular questions or really trying to work out, they've got a syphilis result, they're really trying to work out, always free to call us to work it out because it can take a bit of detective work. So, so just simply request syphilis serology. And as I said, the window period can be up to 6 weeks after exposure. So you've got syphilis-specific tests, and you've also got syphilis kind of non-specific tests, which I'll talk about in a minute. So can you also look at the next slide? Just briefly. Sorry, I did look at this before. Okay, yep, go back. Oh, yeah, that's coming up. So, and I've already mentioned about taking a PCR swab of lesions, and it would always be PCR, syphilis, PCR, herpes. And yes, I've already mentioned too, I'm already ahead of myself. So the PCR test is highly sensitive. It's also very specific. So that's one thing. There's one of the syphilis serology tests, which is highly sensitive, but not especially specific. So I'll talk to that a little bit more in just a minute. So we'll go to the next one. Okay, so these, well, when we're thinking about potential for congenital syphilis, it can be completely devastating, where a fetus can die in utero, significantly disabled, other deformities. So testing on a regular basis, and these are the general guidelines for how often to test. And also, I think even if you've got somebody who's been in a long-standing relationship or they're married, assume nothing, because people still have sex when they're pregnant and they may not be having sex with their long-term partner. So I think it's just, this is what we normally do for everybody. We're not assuming you've had sex with somebody else. This is our routine, it's our protocol. Just completely normalise the conversation. And as well on that as well, this is a recommendation from the Silverhawk guidelines from Department of Health for WA. And so the way they refer to these is you're really looking at this as your minimum kind of testing timeframes within pregnancy. If there is, obviously looking on a case-by-case basis, if there is indication for for maybe more frequent testing or other testing within these kind of, or outside of these kind of periods here within pregnancy, that may be because they may have STI symptoms, maybe they have been having, have had a partner change, or maybe they're engaging in unprotected sex without a condom. In between these kind of testing intervals, that there's the case-by-case basis, testing can be done more frequently where required. But of course, that is only the case if somebody is indicating that as well. So this is the kind of the minimum kind of recommendations for testing within pregnancy. Oh, perfect. Okay, interpretation of results. Yes, it was a bit of a headache when I first started to work all this out. So depending on which lab you use, the first test that they'll do is the EIA or a total antibody test. So if you get a result back that says total antibody or EIA negative or not detected, then we can only assume that they don't have syphilis, but 6 weeks before that test. So one of the important things is that it is highly sensitive, not necessarily specific. So you will sometimes get total antibody or EIA positive, but the other parts of the test, which we'll talk about, are not detected or non-reactive. So we've got somebody that constantly has a false positive antibody, just something that happens, who knows, we don't know why. So then further testing needs to be done, which the lab will automatically do. We already talked about the PCR. So the next part of the test that they'll do is the RPR, which is a rapid plasma reagent test. So it's actually, it's probably good to YouTube it, but it's like a little card, and they put a sample of the serum on these little dots, and each time they put on the reagent, it'll clump together and it'll show a reaction. So that first little dot is a 1, and then the next one is a 2, the next one is a 4, and it goes up 8, 16, 32, 64, 128, and it goes up that way. So that is an indication of how much syphilis bacteria is actually floating around. I've seen one of these go up to over 2,000. So that would have taken the lab technician probably an hour or more. So it's just an indicator of how much syphilis there is. So when you get that initial test result, let's say it's 16. So that's a positive. They'll automatically go on to do another test, which I'll mention. I don't think I've got that on another slide. Oh, there it is. Sorry, it's in my notes. It's okay. Oh, geez. Anyway, move on. So that's the RPR. That's probably the best simple explanation I can give. So then there's a very specific test that's also done, which is either the TPPA or the TPHA. So TPPA is a treponema pallidum particle agglutination test or a particle hemagglutination test. So that's quite specific to syphilis. So what you need is an antibody positive, plus you need at least one other part of the test to be positive, such as the RPR and or the TPPA, TPHA. So it's very medical jargony. So in all likelihood, the antibody and the TPPA, etc., will remain positive for life. It's an indicator of current or past infection. So with the RPR, so you get that number. Once you've treated it, you want to get a day of treatment RPR. So that might be going from a 16 to a 32 or a 64. That's your starting point to monitor success of treatment over the next 12 months. So you want to see a fourfold decrease in the RPR over 12 months. If you do see that come down over 12 months, that's successful treatment. Yeah, I won't go into any more on that one. I think it gets a bit confusing. All right, let's move on. So this was, these are people that we've seen here. This chap came in, so I'm looking over to my notes. So 3 weeks of really significant fatigue. Now, this is where, again, you get back to don't trust the symptoms completely. Had an itchy reaction on the torso, arms and legs, had been to the GP, treated with antibiotics and also for a fungal infection. He'd also had patchy hair loss in the previous few weeks, again treated by a GP for a fungal infection. Hadn't noticed any ulcers or other suspicious lesions. But then he also had said he had some vision disturbance. Now, with patchy hair loss, significant fatigue, widespread rash, again, from a sexual health point of view, potential for syphilis. I've only seen 2 people that I can think of that had, the hair can come out in clumps. So that to me screamed syphilis. So we treated. And he did have a faint rash on his torso and back, and bingo, it turned out to be syphilis. So serology. So this is a nice, clear, neat one where we've had regular testing. So 2021, antibody negative, antibody negative, antibody negative. Then antibody detected, that RPR, 64, TPPA positive. Because of the time frame, it's well within 2 years, we know this is a new infection and we need a single treatment of long-acting penicillin. So after completion of treatment, you want to review them. We do a follow-up check at 3 months, 6 months, and if the RPR is still coming down, then you can go up to 12 months. Very often they will go to negative quite quickly. So, but anyone who's had syphilis, you'd say get tested on a regular basis. Okay, so this was, again, what I was talking about, the day of treatment rebleed. So that stayed at 64, so that was going to be our starting point to monitor over the next 12 months. So, and that could have gone to 128 to 56. So that's our starting point. That's what we look at. You get them back in 3 months. It may go on to 16, then down to 4. Perfect. So when we did the follow-up, you're right on the spot. So when we did his follow-up, it had gone down to 8. We had a really good decrease. And we're like, yeah, this is great, heading in the right direction. Okay, next. So this was a quite significant one. I don't think I've seen one higher than this. This is a chap of ours who was actually positive, which is always so more serious in that people with HIV can be more susceptible to some of the other symptoms, and one of them can be an increased risk of severe hemorrhage. So his RPR on the day that we saw him, and this was only a couple of weeks between tests, started at 64 and went up to over 2,000. So at the time, unfortunately, he wanted to use aromatherapy to try and get on top of the infection, and we can't force people. The old days, you could actually enforce people getting treatment, but he ultimately came back and got treated, which was fantastic. So that's quite dramatic. Okay, so all right, so another chapter of ours, this first ever test. So it came back with the antibody detected. As I said, don't rely on that alone. TPPA was positive, but the RPR was negative. So when we did the day repeat test, it was exactly the same with the RPR negative. So this tells us it's a latent, very long-standing infection, and instead of a single dose of long-acting penicillin, the benzathine, someone like this needs 3 treatments over 3 weeks to get good penetration of the antibiotic into all the related body organs. So that would be a classic late latent, or someone who's been successfully treated. So if you saw the person before that had the RPR 64, and then they test again in 6 or 12 months, RPR negative, RPR negative, RPR negative, then you've got a successfully treated infection. And this is really important for people to know, that these antibody and the TPPA will always be positive. So if they go to a new doctor or a new service to tell people I've had syphilis in the past, rather than, a clinician thinking, oh shit, you've got syphilis. So the patient being aware of their history, the treatment that they've had is really important. So yeah, we'll move on from that. Okay, so this one, in 2022, in May, the RPR was negative, and then the 31st of the 8th, yep. So previous RPR of 8 with the positive TPPA antibody detected, and then we saw the RPR of 4. That's a minimal change. So I should have the date for this one. So previous one, August 2021, we had a definite positive. Then he went to an RPR negative, and then the follow-up check, routine check, was an RPR 4. So you've gone from an RPR negative to a positive RPR, then you've got a reinfection. So your RPR is absolutely vital in detecting reinfection. Right, so probably mention this a little bit as well. So benzathine, benzyl penicillin, not benzyl penicillin. So a lot of you be aware of the nice thick penicillin formulation, which is the benzathine, which is not necessarily the most comfortable injections to have. So we used to decant the 2 separate injections into one, but found for a lot of people that was actually very painful. So my preference is to do 2 separate injections on the upper outer quadrant. So if they do happen to have a penicillin allergy, your second line therapy is doxycycline. For a recent infection within previous 2 years, it's 14 days. So it's 1 tablet twice a day for 14 days. If it's somebody who has a penicillin allergy or refuses the injections, it's doxycycline 1 twice a day for 28 days. One of the biggest problems with that is hoping that people would be completely adherent. If they're missing doses, not taking it properly, you're not going to get adequate treatment. Pregnancy, specialist, move on from there. If you suspect tertiary syphilis, long-standing with severe symptoms, again, specialist advice, and sexual health or infectious diseases. Clinic, and sometimes they'll have to be in inpatient treatment with continuous antibiotic. Right, I'm going to hand it over to you.
So as most of you may be aware, so syphilis is a notifiable condition under the Public Health Act. So the notifications must be completed by a medical officer or nurse practitioner, or the relevant person in your service and that must be done as soon as possible. So the form now, you've got the Syphilis Enhanced Surveillance form. It is an online form. So the recommendations are within the Silver Book is that the notification must be done within 72 hours of diagnosis, or as soon as possible. So I've got a screenshot here of what the header of the Syphilis Enhanced Surveillance form looks like. I believe previously, Gary, that it was people might have done the kind of a physical form as well, but now it's just moved to just the digital form. That needs to be completed rather than having to do both or into the physical form.
So if anyone is not aware of or have access to the electronic online notification forms, let us know. It's just so much easier to go to the online form, type in the details, click submit. Old days you'd have to fill it out manually, you'd have to post it, or you'd have to scan and fax. So these ones are much, much easier.
Yes, you wanted to add on for this?
No, and I know very kindly you put nurse practitioner, but any nurse.
Any nurse
so anybody can do the notification. It should be a clinician, but yeah. So and on the form it will have, where do you think the person met the partner from whom it was acquired? Do they know from whom it was acquired? Just answer to the best of your ability. And if you don't know, you don't know.
Contact tracing.
Okay, so contact tracing, this is going to sound obvious. We talk about contact tracing for gonorrhea and chlamydia, incredibly important. HIV, incredibly important. Syphilis, incredibly important because of the nature of the infection, where it's not going to be managed by the immune system and will remain highly infectious for quite some time. So when we're talking to people, again, normalise the conversation. Nothing about, who have you had sex with? Oh, you know how dangerous it is. Like talking to somebody, the chap I remember who had latent syphilis and was married, I said, we just really need your wife to know, because she could have syphilis and it can cause quite severe damage. We will assist you through that process. And we come up with a really good story, basically. He took her for test and she did have syphilis. Because it was a latent, it could have been before they got married. So it is always difficult when somebody is currently married and have got or in a long-term relationship and they've acquired it during the relationship. But it's so vital that the person knows, and that's a delicate conversation, needs to be diplomatic, but also it can't be left undone. So, these are all probably fairly standard, but if contacts are or could be pregnant, don't presume gender of contacts. And it's good to ask where people have acquired the infection, such as do they meet on Grindr? Okay, likelihood of getting contacts could be none. Do they go to sex on premises venues? Do they go to sex shops where they've got little booths out the back? Do they go to sex parties? Do they go to beads? So this is all really helpful from a public health point of view. And also asking about behaviour, because I've had people that I've tested and I've said, how many sex partners have you had? I had somebody say none. I was like, well, why are we testing? He said, I've had oral sex. I'm going, that's sex. So it can be transmitted through oral sex, anal sex, fingers, tongues, toys, any kind of intimate contact. So, so asking, what are your sexual practices? And always offer assistance in contact tracing, because it can be quite stressful, and also just making sure the person's probably going to be under a great deal of stress anyway. So it's like, it's okay, we're here to help you. It doesn't have to be done immediately. Just so, because you want to keep the person engaged.
I was put down there as well in terms of emphasising that confidential nature when it comes to contact tracing. Obviously, if somebody does return with a positive result with then being a notifiable infection, that information will have to be passed to the Department of Health for surveillance purposes. But when it comes to actually that kind of contact tracing in terms of them going and reaching out to maybe past sexual partners or current sexual partners, There are sometimes confidential ways that this can be done. So maybe if it is somebody that they don't have contact with anymore, or maybe that they don't want to be the one to tell them for any range of reasons, whether it may be safety or I guess it could be their own individual reasons, that they are at the end, they actually will send out a document that have got some different referrals or kind of some different sites, and on there is some anonymous notification services. So people will need just a phone number, and then they can pop in what they're tested positive for. There's no way to trace that back to an individual, so and they don't need to include their name in it. Or maybe if it's a clinician, might be able to call on their behalf and say, hey, somebody's tested positive, you should come and get a test as well. Whatever it might be, to be able to support that person if there is reasons that they aren't able to contact them or don't want to make themselves known to a particular person, that there is ways that this can be kept confidential as well for their reasons as well. Obviously, though, we do want to be encouraging people to have that conversation where possible. But like Gary said, as clinicians offering your assistance in the contact tracing, whatever that may look like for a person, and in the state that they're at the time too.
So there was also one other thing that I had thought of earlier is when we've treated somebody for an early latent or infectious syphilis, we'd say no sex for 7 days or until the lesion or the rash is completely resolved. So that's just something to bear in mind there. Yeah, okay.
Alrighty, so we'll just talk about now just normalising the conversation. And Gary's talked already at some of these points here, which would kind of within the context, which is really helpful. So kind of looking at how we can kind of destigmatise talking about syphilis, but also sexual health in general too. It may not always be that somebody's coming in for a sexual health specific test. If they are, great, normalising the conversation about talking about syphilis within that. But if we are kind of talking to it within a kind of a general kind of whether it's general kind of appointment, healthcare check, or maybe talking to a community, if you're working within kind of a community facing role, whether it's health promotion or kind of a non-clinical role too, different ways that we can kind of normalise bringing up syphilis and sexual health more broadly is really important. And different ways we can go about this. Trust and rapport are really key. It may not be that we may not want to kind of open up to and talk to somebody and disclose potential behaviours that may have put me at risk when it comes to sexual health. If we don't have that kind of trust that that information is going to be kept confidential, or that they're going to be talking to somebody that's not going to judge them, essentially. Starting with kind of actually prompting the conversation, not relying on somebody to actually bring up the topic with you. It may be because they aren't comfortable with it, they've had to bring it up to a clinician before, or maybe that they aren't aware of it. Maybe that's not relying on the patient being educated first to bring it up in an appointment or in any kind of chat. Within your own kind of context. Also asking a person what they want to know too. So say that they haven't got a positive result back. Obviously there are certain things that you'll be wanting to kind of do and kind of letting them know, and to kind of things that we may think are the most important bits of information for them to know in that moment, but that may not always be what they need to know in that moment. It might be reassurance, it might be kind of depending on, it's really important to see what they want to know as well, so that we aren't just kind of giving them the kind of information that we think is applicable, but there's so many other needs there that are kind of going unmet too, because especially if it is something that could be quite distressing, and other kind of things that are going on in their life as well, important to check in and actually go, okay, what will be helpful for you to know in this moment. Avoiding making assumptions, we spoke to as well, so not making assumptions about particular behaviours, about particular partners they may have been with, about what kind of what they engage in or what they do outside of that appointment or that kind of conversation, and really kind of holding space and to disclose what they would like to disclose, but also not making assumptions that everything that they've told you is the full extent too. Using neutral and inclusive terms, particularly I guess if we're talking about partners as well, not assuming the gender of partner or particular practices as well. Respecting and reassuring confidentiality, particularly this can be a concern for people, especially in kind of smaller communities. If they are talking to somebody that they might be a nurse or disclosing it to a practitioner that they might see at the shops later on that day, or maybe that they know in social circles, that can often be a big barrier for people wanting to access testing. So whether that is reassuring that confidentiality there and respecting that as well, which obviously as clinicians you will be needing to do anyway, but even working within other kind of aspects of healthcare as well, that people knowing that they're not going to be, oh, hey, I saw so-and-so coming at an STI test, just knowing that those sort of things won't happen as well, or offering options to maybe see a different clinician or what online testing then might be available. that they can access it in a different way to help kind of overcome those barriers. Including it in regular healthcare checks as well. It can be a really good way to introduce it as well. So if somebody's getting bloods done, you can say, hey, we're also, this is, syphilis is quite common. We'd like to include syphilis in our blood tests at this clinic. Would you like to, give a little bit more information, but then also would you like to include it in your bloods as well today, while they're getting everything else checked out as well? But, often have that included in a serology too. That could be another way to kind of normalise that conversation or normalise that kind of testing within kind of a general health kind of context. And even if it's not going to be testing happening at that time that you're talking to them, even just introducing the idea of having a test or the idea of talking about syphilis or talking about sexual health, it might just be just enough to plant the seed. It might be the next time that they come and see you that they might be interested. Maybe it's a time afterwards, but it might just be planting that seed that they're a bit more aware of, okay, this is something that's going on. Maybe I'll think about this if I'm comfortable to the next appointment, or if I think this is right for me to get tested for, I can bring it up in the future as well. It may not happen at that moment, but there still can be a conversation that can be had later down the track as well. Anything else you want to add?
I think it's good.
Probably on the spot there.
Yeah, I think so. Mm-hmm.
Awesome. So I'm just going to go through now a couple of resources as well, and then we'll wrap up for the presentation side of today and we can answer some questions. So we'll just start to touch on the campaign we have coming up at WAAC that is specifically focusing on kind of the target kind of population, looking at gay and bisexual men and men who have sex with men. So this is a refresh that was initially launched last year in 2024. Of a previous campaign that we had. So we've had these was disseminated across SAPVs, different event venues, beats, anywhere that we could kind of get it throughout the community that we have had disseminated it. And we'll be looking at it doing a similar kind of, I guess, dissemination of information and resources this year round as well. So we have got these kind of posters and everything available will be on our website. I'll send out the link as well and the follow-up email, but you can also order some posters too. So if you have a condom order that you're placing, you can order these posters. We can include these in for free within your order of those. Otherwise, if you're in the metro area, you're welcome to come and pick them up. Otherwise, we'll also have digital copies too, or if you did want them sent out as well, please let us know. And I believe we've also got, I know last year we had some safe sex packs specifically with this kind of messaging on it too, so we'll hopefully be bringing those back as well for this year. Just a couple of resources here that are quite useful. So ASHM have got a decision-making tool around syphilis, so you can actually kind of go through and look at specific kind of contexts or kind of scenario that you can put in kind of checkbox, and will help kind of give some guidance of what kind of the best outcome or what the next kind of steps would be. So this is a really good tool if you're kind of just wanting to kind of process things, or maybe if you maybe before, or if you want to speak to a clinician wanting to call M-Clinic, this could be another tool as well that you could use to assist in decision making with treating and testing for syphilis and managing syphilis. We've also got the Silver Book there, so that is the guidelines set by the Department of Health of WA, so looking at it within state specific. And then we've got these two ones here. Did you want to speak to these two, Gary, the last two?
Okay. Yeah. So one of the ASHM's put out this single sheet checklist. So, I mean, you may find it's quite busy, but it can be quite helpful just to give you a one sheet check. Could it be syphilis? And it breaks down everything, so that's available online. The STI Atlas is really handy if you're not familiar with it. It gives you some amazing photos of what you could expect potentially to see with all sorts of infections. So that's a really good one to check out. And the Melbourne Sexual Health Centre has also got an excellent website. So you've got lots of options to check things out.
And so with the ones that we've mentioned here today, if they're PDF form, we'll include them in an email out after the session today, or I'll also include the links to the different websites we've spoken to as well. So that is the end of our presentation today. Let's pop up an evaluation form of if you have a moment, be able to scan this, and I'll send out a link afterwards too. But I'll stop the recording, and if anyone has any questions, now is the time you can ask us. You can either pop them in the chat, or you can turn your microphones on, maybe pop your hand up. And yes, so welcome to ask any questions there. Just with that as well, so I'll stop the recording. If it is any specifics